Please welcome Director of the Sanford Center for Aging, Peter Reed.
Delighted to see all of you here today. I think we're going to be in for an amazing talk tonight, looking at healthy systems and healthy aging, which are really critical issues for us here in Nevada. When you think about the lack of integration of services and the challenges with our workforce and all of the things that are going to be necessary for us to continue to serve elders across our state, which is aging very rapidly, as all of you know. And so I just want to take a minute and share a few quick points about what we're doing at the Sanford Center for Aging and how that relates to this event. As you know, the Distinguished Speaker Series that we host at the Sanford Center is part of the Sanford Center's Aging Research Collaborative. And through this, we try to bring together the community with our faculty, with our students, with all of our partners, both here in Reno and beyond, and bring the perspectives of national leaders in the field of aging, research, and practice so that we can all start to evolve our thinking in terms of the kinds of things that are going to be necessary for the work that we're doing in supporting elders. And so these events really serve to have some collective education for all of us. And again, this evening, with the topic of healthy systems and healthy aging, it's going to be very pertinent to all of the work that we're doing throughout the community. In particular, with the Sanford Center, we are right on the cusp of launching a new interdisciplinary geriatric clinic to serve Northern Nevada, and that is going to, oh, thank you. There are no comprehensive geriatric services like it in the area, and after a diligent assessment of the needs of the community and a very in-depth planning process over the last 18 months, we're excited to be able to launch in early November and start to see patients, offering them with a comprehensive whole person assessment, really getting to know the person from the medical perspective, from the psychosocial perspective, in looking at their medications and understanding their life story and really who they are as an individual, and then working with our team of providers to be able to collaboratively plan a direction for connecting them with the resources they need in the community to maintain their independence, promote their well-being and quality of life. And so this will be a piece of the larger system across Northern Nevada as we connect those specialty geriatric services with primary care and with primary care geriatric services and with community organizations that have a variety of different supports and services, all of which are intended to enhance well-being. But it's that integration of the system that ultimately is going to help to lead to the outcomes that we want to achieve in enhancing quality of life. And so with that, we're hosting this event this evening, which is so very well related to that. And our speaker, Heather Young, is from the School of Nursing at UC Davis and is a nurse leader in this field. And so the Sanford Center is delighted to partner with the Orvis School of Nursing here at UNR to bring this event together. And so we're co-hosting this event, and I want to thank Patsy Rashala and all of the nursing faculty and students who are here with us this evening. Let's give all of our nurse partners a round of applause. And we're just delighted with the interdisciplinary collaborations that we're able to achieve when we really bring together all of the different disciplines across the Division of Health Sciences, from the School of Nursing to the School of Medicine, the School of Social Work and Community Health Sciences, and then for the Sanford Center perspective, really bringing all of them together with a focus on aging and aging-related research. And finally, I want to take a moment to thank Colette Witt and Gary Aldex and the entire team from the Sanford Center who do such great work in hosting and coordinating and leading these events to make them as special as they are. And so please join me in giving Colette and Gary and the team a round of applause. And with that, I would like to introduce and welcome to the stage Dr. Patsy Rashala, who is the director of the Orvis School of Nursing. Please join me in welcoming Patsy. Thank you very much.
Okay, thank you, Peter. As Peter mentioned, we have a number of healthcare partners that we work with to provide the best care that we can in a holistic manner. Many of you out there know that whether it is nursing, medicine, physical therapy, respiratory therapy, we tend to be a little bit territorial. So I am delighted this evening to introduce to you one of our own from nursing. Dr. Heather Young is the Vice Chancellor for Nursing at the University of California, Davis Health Center, and also serves as the Dean and Professor of the Betty Irene Moore School of Nursing. She is indeed a nurse leader, educator, scientist, and nationally recognized expert in gerontological nursing and also in rural health care. She researches healthy aging with a particular focus on the interface between individuals and families, as well as informal healthcare systems. Her systems research includes medication management and safety in rural assisted living settings and hospitals, as well as the use of technology-enabled care, such as telehealth and community-based strategies to promote health. It is my distinct pleasure to welcome to the podium Dr. Heather Young. Dr. Young?
Thank you, Dr. Ursula.
So much.
What a pleasure. It's such an honor to be here with all of you today. Thank you so much for coming, and I'm so excited to have the afternoon and to spend the time with Dr. Reed to learn more about the Sanford Center, and then to spend some time in the School of Nursing with faculty who are in that program and working with gerontology. And it was just a wonderful day to learn about what's going on here in Reno. And it's just a wonderful thing to see how much you're accomplishing and how much potential there is for wonderful, wonderful work. So it's a great honor to be here. Today I want to talk to you about healthy aging, and particularly take a position on it in looking at what does it take to grow old in a healthy way? How do we value ourselves and value our older adults in our community in a way that we can actualize our full potential as we age? And what do our systems need to look like to support healthy aging? And I'm going to look at three systems in brief that I think are important. One is the healthcare delivery system. And don't worry, I won't bore you with that for really, really long, but I have some thoughts about that. I'm going to think about technology and how technology as a system can support healthy aging. And then I'm going to talk about family caregiving. And those are the main areas that I want to focus on. And I raise all of these issues because they really are fundamental to thinking of any kind of interdisciplinary approach in care. The issues of aging are complex and are unfolding over time, and it takes many different perspectives to really understand them fully and to design the solutions that are going to actualize our goals. So to start off, when I first entered the field, which was now about almost 30 years ago that I started being interested in older adults, I actually started out as a nursing assistant in a nursing home. And when I first entered the field, it was something that was somewhat unique to be interested in older adults. Nobody really wanted to hear what I was interested in. When I was 20 and I'd go to parties and people said, what are you interested in? I'd say older people. That was the end of the conversation. And now when I go to any kind of social event and I say my area is older adults, man, I am so popular. And it's not because I'm that scintillating, it's because almost everyone I meet is dealing with issues of aging, either themselves or in their families or people they care about. And for many years I wrote grants, and I'd always write the reason that the people should fund me was because we were going to have so many old people in the future. And I'd write about the age wave that was going to hit the shore. And it was always my call for people to fund me or publish what I was writing. And it's so interesting to look now and see that the age wave is actually hitting the shore. It's something that many of us for many years were expecting. And it is full on a tsunami that's going on right now. And so your focus on aging here at the Sanford Center and the Orvis School of Nursing could not be more relevant and more important. The growth that we're expecting in older adults is really quite dramatic, and this slide summarizes some of the statistics. What's so interesting about it to me is that the fastest growing group of people are those who are over 85. And that's really great news because it means that people are living longer. Oftentimes you think about the things that kill you, and they tend to kill you when you're younger, when you're 50 or 60. The single cause of death types of issues happen earlier in life. And the people who survive and dodge those bullets, if you will, are the people who end up living a very long life and are now healthier than they've ever been in the history of the world. And so we're now at a point where there are actually 3 generations over 65. And so we're at a point where we really are seeing a lot more people in our society who are older, and with a great deal of diversity around that age. When you think about it, there are people who are working at age 65 and all the way up to 95. There are people who are vitally engaged in the community, contributing culturally, socially, in so many different ways, as well as on the other end of the continuum, people who have significant impairments and needs. And it's a very heterogeneous group of people who are over 65. And that's becoming more and more complex as time goes on. Importantly, we're seeing a real change, and this is a 6th-generation family, which is not that unusual. We have little Ellie Mae, who's 1 month old, and her great-great-great-great-grandmother is 103. And what's interesting about this family is you think about all the people in the middle. There are quite a few in there who are in their 40s, 50s, 60s, 70s, who are not only thinking about their parents or grandparents, but are also thinking about grandchildren, great-grandchildren. So the complexity of what these women are facing, and 3 of them are over 65, the complexity of what they're facing is really different than ever before in the history of the world. I mean, we have more grandparents now on this planet than we've ever had. And I would really submit that aging and the issues of aging are becoming of importance to absolutely everyone. It doesn't matter what your field is or where you stand, but in some way the issues of aging are touching us and are important. And the complexity of what families are managing, not only with the age differences and the many different demands there, but the distances that we have. So many of us have family in other countries or other states, other communities. And the ability to connect is changing too. So the complexity of aging has really moved a long way since the Waltons, where everyone was under the same roof. When you think about what people really want from aging, and what do we want as we get older, that's, I think, a really vital question. And I know that at the core of the Sanford Center, the value is about the person at the center, elder-driven care, and really thinking about what the values and the beliefs and preferences of older adults are. AARP is always at the forefront of trying to figure out what older adults want and where they're going, where the puck is going for older adults. And they did a survey, and this stands up over time. It's repeated many times, and what comes out over and over again when you ask people, what do you want as you get older to be healthy? And living independently is a big value. A lot of people want to be in their own homes. And in fact, only about 5% of people in the country are actually in organized long-term care settings. People actually do live in their homes for most of their lives. The challenge is what kinds of services and supports does one need to be able to accomplish that goal? But it's a very strong driver and a very important force for people. Maintaining health, wanting to be as healthy as possible. And there's been a lot of wonderful work in the last couple of decades on successful aging that says that it's not about being free of disease, because many people are dealing with different conditions, but it's about being as healthy as possible given what's going on. And so people want to maintain their health. Then the things that are important are being with family, traveling, getting in shape, which really links very nicely to being healthy. Having an interesting life with hobbies and interests that are important. Saving, retirement security is a very important issue. And for baby boomers, I think we've done the worst job of anyone ever. And there are going to be some very serious conversations coming up around financial security for older adults as the baby boomers age. And then reestablishing and deepening friendships. It's a lot easier to rekindle an old friendship than start a new one. And I think Facebook and other social media is a place where people are really starting to connect a whole lot more, to find people who were important in their life previously and bring them back and rekindle the relationship. So this is an important set of goals, and I always like to keep this in mind at the top of every time I think about services or supports for older adults, because whatever we do in the healthcare delivery system, That's a very tiny portion of what really matters to older people. You don't see on this list, I'd like to have a really nice healthcare system. Although if we don't have a nice healthcare system, it's a real problem. But when we really think about what's important, we have to keep in mind the goals and the expectations. So as I think about planning for systems of care for older adults, I always start with what do people want, which we just talked about, and then I think about, so what's coming from a population perspective? What are some of the big things that we should be planning for and considering? And everybody, I'm sure, hears about Alzheimer's disease and its growth, and it's something that certainly is affecting 1 in 9 people now in our country over 65, and 1 in 3 over 85. And it's something that is going to have an increasing prevalence with time. Right about now, about every 67 seconds someone is diagnosed, but by 2050 it'll be every 33 seconds. So there are a lot of people working on a cure and trying to deal with it from that perspective, but unchecked, we're facing a really significant issue. And it's not just a matter of the loss, the cognitive change that happens for the individual, but the implications for society and for families of how we might cope with something that's so important and so large. Arthritis and chronic joints, I don't mean to depress you, I promise you I'll get more cheerful in a minute, but about 45% of people are dealing with arthritis, and your chances of having a total hip replacement are 6% by the time you're 80, and your hip replacement 10%. So I think about that and I think, wow, that's a lot of rehab that has to go on. That's a lot of grab bars and bathrooms that need to be there. That's a lot of community services that are going to need to be thought about to support people as they deal with those kinds of things. It also is a big driver with workforce. When you think about orthopedic surgeons and nurses who know how to care for people with orthopedic issues, physical therapists. So all of these prevalent diseases will drive a great deal, both in our families and our communities, as well as in the workforce. Depression, to be depressing again. There's 7 million people now who are affected by it, who are older adults in the country. And actually the World Health Organization is projecting that by 2020 it'll be the second leading cause of disability in the world. And it's an issue that certainly is not getting the attention it deserves. And when you look at prescription drug use and the kinds of issues that people face, there are a lot of very complicated psych mental health types of considerations that definitely need system solutions. Diabetes and obesity are somewhat linked, and it's surprising to me to look at the prevalence of diabetes in older adults. It's over a quarter of people who are over 65 have diabetes. And obesity is very tied to that. Much of it's type 2. And so obesity is something that we're starting to see more and more in children. And when I think healthy aging, it's got to start when you're born, actually when you're conceived. And some of the issues that you see today in children with obesity, sedentary lifestyles, are really important public health issues if we want to have healthy aging and we want to actualize that really long life. So these are the kinds of things that sort of form the backdrop, I think, as being some of the most common issues that we should be really having the forefront of our minds as we consider the types of programs that are needed in terms of our assessment, in terms of the different systems that we need to create. And in fact, so much of our healthcare system is geared towards acute things, a crisis, a car accident or a heart attack, whereas really chronic diseases are the actual biggest chunk of cost, time, and energy. 75% of our healthcare costs are around chronic diseases. And so it's something that many, many people are dealing with. And chronic diseases include such things as hypertension, diabetes, obesity. And the thing that I find so interesting about chronic conditions is the underlying causes are often attributable to 4 things: diet, physical activity, tobacco, and alcohol. And so here's the part where I give you really good news. The good news is that chronic diseases are actually highly modifiable. And if I was personally paying for healthcare in the United States, I would put as many bucks as I possibly could into dealing with the chronic diseases and the chronic conditions to get people as healthy as possible so we don't need the expensive stuff. We don't need the healthcare systems that cost so much and are oftentimes so dangerous for us. So chronic disease is something that is highly modifiable. It's something that we each have an opportunity to influence. Even if we can't prevent ourselves from getting a chronic condition, we can certainly change our trajectory and how we deal with that, how it unfolds in our bodies and our families. And the focus with chronic conditions is much more on thinking about how to improve symptoms, how to improve quality of life, how to improve our skills in coping with the issues that we have, and preventing the complications that occur. And more, this is some of the more good news, is that our healthcare system, which all of you know, and I don't have to tell you, is incredibly fragmented. It's a broken system. More and more, we're seeing a shift towards changing the way we think about care to a much more coordinated and holistic approach to thinking about people as they go through a trajectory of a certain condition. So in the past, if somebody fractured a hip, you'd go to the hospital, they'd do their thing. You may go to a nursing home, they'd do their thing, and the home health would then follow on and do their thing. And they may not even talk to each other, and there'd be no consideration of any coordination. And as we look to the future, we're seeing much more of an emphasis on trying to create much more coordination and a plan for the long run to get the person back to the best possible function. And that's really a new approach, and much more thinking about how to reach into healthy communities and keep them healthy. So there's some shifts there. And I think technology can also help, and I'll elaborate on that a little bit more soon. So first, to talk a little bit about the health systems. I had the opportunity last year, I was honored to be asked to serve on the Presidential Council of Advisors on Science and Technology, which is actually a group, and I was there as a committee member looking at how systems engineering can improve healthcare. And this is a group, the president under Roosevelt this group was convened for the first time, and it's a group that advises the White House on issues that are important to society, but really focuses on the evidence base and makes recommendations that could be achievable by the executive office. So we've seen work in this area on a variety of different topics around energy, around water, and this last year we were asked to look at healthcare. And so there were a number of recommendations that came out of it that I wanted to share with you today, because I think as we imagine systems, these are the kinds of things we should be focusing on. So the first thing is we looked at the issues in our broken healthcare system, and we thought about how systems engineering, meaning looking at that from a systems perspective, could improve the outcomes. We recognize first and foremost that payment's big. That if you're paying, whatever you pay for is what you get in terms of behavior. So that we needed to look at aligning payments so that there would be incentives for healthcare providers, hospitals, and systems to do the right thing to improve health. And actually, we've already seen actions out of this. The CMS director has issued some expectations that alternate models have to be the majority by 2018. So the speed with which we're going to adopt new ways of organizing care is going to accelerate. And this is something that's outside of the political process. It's purely part of the policy regulations under the Centers for Medicare and Medicaid Services. So that's going to start to change, and you'll see and hear more of it. And I heard a lot about it today as I was talking to your colleagues in this community, that it's starting to happen here. The second issue that we really thought about was increasing access to relevant health data and analytics. It's really ironic how we have so much data in this country, and it sits in silos, and the silos just don't talk to each other. So, for example, you have an outbreak, and we just dealt with this at Davis a couple of years ago when there was the problem with the spinach and the salmonella in the spinach. Well, it was out in the fields, and there was this issue, and the first thought, was it was probably some tainted water, so it needed to be a USDA issue. So USDA got involved to try and solve it. Well, then they figured out, because they put cameras in the fields, that it wasn't cows, it was wild boars that were contaminating. So then they'd stopped working on it, and they handed it over to Fish and Game. So then they worked on it for a little while. I mean, things get passed on. CDC got involved at some point. The FDA got involved at a different point. But all these different government agencies work on the data that they're responsible for, but they don't talk to each other. When you think about human health, we have a lot of data at the county level. The public health departments collect a lot of data, but that doesn't talk to Centers for Medicaid and Medicare Services who are paying for the services. And it doesn't talk to the CDC, where we were tracking communicable diseases. So these data sets don't link very well. So one of the things that we recommended was that we create a person that would report across these agencies and be responsible for bringing data together so you could actually understand what's going on with people and populations and communities better to integrate the approach. So that was a really big deal, and that person's been appointed and is underway now to start to bring this information together. Another big data source is our electronic health records, which oftentimes up until recently has been very proprietary, and we all have privacy and security concerns. But there should be a place where we can start to look at that when it's de-identified from the actual people to improve the quality of what we're doing. We also thought about providing assistance with how to do this, because this is thinking about a new way of operating. So technical assistance, involving communities in important ways. And some of you serve on community advisory boards, and it's about what do communities want? How do communities want to use their resources? How do communities view their issues? And really importantly, what are the strengths? Because oftentimes when we design systems, we think about what's broken, we got to fix it, instead of saying, what is the great strength of a community? And where are their assets in terms of their human capital? And how can we mobilize that differently? And then sharing the lessons learned, very importantly. And then finally, health professionals and training them in new ways. Because as a nurse, I was trained and I was educated to really think about the patient in front of me, the one person I was caring for. That's how I started in nursing. And it took a long time to add the perspective, which is about the population you're caring for, thinking about the systems of care and how to deal with the policy aspects. And we're really seeing this as fundamental knowledge for everyone now, whether you're a nurse, a physical therapist, a physician. We've got to know better how to work with each other and how to fix the systems as we use them and work them. And so that's another element of our recommendations. So as I think about healthy systems, and these are care delivery systems, I think there's some core principles that are important. One is having really a focus on being person and family-centered, understanding deeply what a person and the family wants and would like to see happen, and how to engage the person and the family in coming to that. The second is looking at a trajectory of care, continuity over time, rather than I have this problem this month, and then in a year I'm going to have another problem with a different group of people who'll be worrying about me. And really linking it in terms of what do we expect to have happen over time, and plan care according to what's fairly predictable trajectories for many conditions. The idea of care everywhere. We used to think about healthcare as the white coats, where the white coats lurk. So it's either in hospitals or in clinics, and that's about healthcare, and that's it. When in fact, people are living with their health and their health conditions day in and day out. I'm working with a group of diabetics now on a project, and they say, you know, I wake up with diabetes, I go to sleep with diabetes. It's not something that only happens when I see you. It's something that's part of my life. And so thinking about how to reach people and provide care appropriately. This is really important for rural communities. You grapple with this here, I know, in the state of Nevada, of how to get care to where it belongs in the community. Very high coordination with strong communication, being willing to listen to one another as interprofessionals and make sure we get the right person there for the right time. Looking at people that we're caring for from the perspective of their values first and their goals and the health, function, and the context. And then more and more looking at self-management, having and helping both professionals understand how to do this, as well as people who are living with different conditions, about how to manage it better on our own. And improving our connections with each other in terms of peers and peer support, learning from one another. So these are some of the areas that I think are really of the most promise to improve our systems of care. So now I'm going to turn to technology and innovative approaches to both in models and also roles with technology. And first of all, I'll start with, whenever I say technology, I'm talking about older people, I hear the message, well, that's not a group that's really adopting technology very much. And actually, I was recently giving a talk in a community to 500 people, and I gave them red and green pieces of paper, and I asked those who had a cell phone on them to raise the green paper, and the room was almost completely green. In fact, I'll ask you all, raise your hand if you've got a device of some kind on you right now. Oh my gosh, look at that, see? The entire audience just about has some kind of device. And what we're seeing is great adoption among people who are older and also people who are of low socioeconomic status. Technology is becoming more affordable and it's becoming much more ubiquitous. And so it's something that many, many people are starting to use. And the thing that I find most interesting about technology and aging is that people who have chronic conditions use it even more than the general population, because it's a source of information, seeking information about one's condition, seeking referral, seeking ways to connect to other people who have that. So it's something that's increasing all the time. And in fact, how many of you have actually sent a text or an email today? See, you're busy. How many of you have been on Facebook? Okay, fewer. What about tweeting? Oh, a couple of tweeters. How about searching on Google or in some search engine? Oh, wow, a lot of you I'd love to know what you all are searching today. But these are all forms of media that are very much in use. And they're, in many ways, it's happening over here, and our health system's way over here. And we're not connecting them yet in meaningful ways. And I think some of the great successes that are going to be coming in the future are where we start to integrate, where people are working in their social world and the world of social media with what goes on in the health system. The other thing that's important to note about all of this media is the data that's behind all of it. There is so much data being generated. And Eric Schmidt from Google said that every 2 days we create as much information as we did from the dawn of civilization up until 2003. And now, you have your cell phone on you. It's collecting the data of where you've been today and who you've connected to. There's so much information, and some of it's garbage, quite frankly. But there's a lot of it that's really good information, but we don't have the analytics yet to figure out what to do with it. So that's something that I think will keep a lot of people busy in the future. So I work with a group at UC Berkeley. It's a collaboration between Berkeley, Davis, Santa Cruz, and University of California, Merced, called CITRIS. And it's the Center for Innovative Technology Research for the Improvement of Society. Whew. How you like that? That's why we call it CITRIS. It's got kind of a crazy long name. But there are a few areas that we're looking on, and it's a very interesting collaborative. We have nurses and physicians, public health folks, but also engineers, anthropologists, design people. A lot of different folks are collaborating. And there are a few things that we're thinking about in terms of technology. I just wanted to give you a glimpse. So as far as the body goes, there are a lot of different sensors and devices that are now being developed and tested that help us to maintain to monitor our physical status and our mental status. Sensors and monitors. There's actually an app that can be on your cell phone that if you have some kind of a psychiatric problem, and someone's not sure you're taking your medicines, the tone of your voice can be memorized to such an extent, not what you're saying, but the affect and the tone of your voice can give a clue that you haven't been taking your meds. So that's something that's very passive. Some would say very much Big Brother, but with the consent of a person, if someone wants that kind of support, that someone could help them to remember, that's something that could be available. Now, all of these issues I raised to you have the ethical dilemma of, do you want to deploy this or not? These are available, though, and there's more and more research going on about under what circumstances can this be helpful? How can it be healthy and helpful? There's monitors for heart rate and for all many of your body functions, including with malaria, being able to use a cell phone and put a drop of blood on it and get diagnosed across the world. So there are many different technologies that I think are going to change the landscape dramatically in terms of diagnostics and treatment. and managing chronic conditions. Then the home environment, there's a lot of technology that's being developed that can very passively manage the home environment. Microsoft's done a lot with this around smart homes, being able to have the temperature go up in your house when you're about to go home from work, and memorize your patterns and change lights and heating according to that. And then passive sensors. So if you're a distance caregiver and you've got someone that you care about in another state, you can know whether they've got up in the morning by 10 o'clock or not. And if they haven't, you can call them and find out what's going on, because there's a passive sensor in the bed. You can have their trackers in the hallways where you can see the movement and the gait. And there have been some really good studies that have shown that people slow down a few days before they end up getting sick. And so you could actually anticipate earlier that someone might have a problem soon. And again, you've got to judiciously use these kinds of resources, but they're there and starting to be available to help manage care. The third area is in the community. So these are technologies that are out in the social world. And this one website called Patients Like Me some of you are nodding, is a website that many people are starting to find very helpful, because it's a peer support place where you can go and talk to others who have a condition like your own. The graph on the right is showing the adoption of using social media, and it's really on a curve of many, many people getting engaged. And then for caregivers, combining all of these different possibilities, being able to think about how to provide support from a distance. Or even if you're a working caregiver and you want to be able to prompt and remind someone, support somebody who's in their home. So there are a lot of different monitors and alarms and different sensors that can be made available. And then telehealth, of course, is another way to connect with FaceTime or other kinds of connections. So there's a tremendous amount of explosion in technology. I want to just share briefly with you some research we're doing at Davis. One is looking at improving health and diabetes. And what we're doing here is trying to change the conversation about health. Because when people go in with diabetes to a primary care provider, the topic usually is, well, how's your hemoglobin A1C? How's your blood sugar looking? And it's not starting with the person's goal and how they're doing. So what we're doing here is we're working with individuals to identify what they want to work on with their diabetes that are important to them, and what challenges they'd like to address. And actually the majority say they want to do physical activity or diet. And then we're using sensors like a Fitbit or other kinds of sensors for them to set their goals and track that. And have created a dashboard that then comes into the electronic health record when you go in to see the primary care provider, that would pop up and would say, Dr. Reed, your patient Heather has been really trying to walk more, and I just want to share with you that in the last month, 90% of the time she met her goal. Please say congratulations and encourage her. So that it changes the conversation, but it starts with what the patient's been trying to work on. And so that's an approach that we're in the process of designing and testing right now. A second one is the PREEMPT study, which is around chronic pain management. Many people suffer from chronic pain, and it's something that's very hard to treat and to know if this works better than that, because you don't try both things at once. You have to try one thing and you try another thing, and then you've got to remember how the other one went to see if it was better. And so this is actually a study that's using the technology to record how someone responds to a treatment. So say this week I say I'm going to give you a prescription of drug for your back pain. You try that, and you're prompted by the cell phone to register how much pain you're in and also how your mood's doing. And then next week we're going to try massage and physical therapy and heat and massage, and we're going to do the same thing. And then you'll come back and you'll visit with your clinician, and you'll find out which one actually, when you record it in real time, works better for you. Or under what circumstances does one thing work better than the other. So it's giving real data in the real time that helps with decision making. The next one is for cancer care, helping the person create a personal health network to coordinate the care that's going on and manage the various aspects. And so this is, again, putting the person at the center and using technology to improve communication. So we're testing these different approaches, and we're looking at the issues of, do people want it? What do they like about it? How can we modify it? And it's really quite an interesting area of research. So now I want to turn my attention to the last group that I want to discuss today, which is family caregivers. And to say that Rosalind Carter actually said there are only 4 kinds of people in the world: those who've been caregivers, those who are current caregivers, those who will be caregivers, and those who will need caregivers. And these are 5 older adults in my life who I worry about, and I worry about them on a daily basis. Many of us can identify people who are in our lives that are important to us. And so it's something that we're all dealing with on a regular basis. Most of the caregivers are really providing the vast majority of long-term care in this country. More than 80% of any kind of care that's being provided is not being provided by systems. It's being provided by families and friends. So it's something that's going on. Over a third of all households are actually dealing with caregiving. And yet it's such a quiet topic. People don't tend to talk about it at work as much. Oftentimes you'll see the pictures of kids and what's going on in people's lives with young families, but it doesn't seem to be as acceptable to talk about what's going on in our lives with older adults in our families. And yet it's something so many people are grappling with. Many people are actually old themselves who are providing care, and then a lot of people are working while they're providing care, and the challenges are really important. So it's something that is really becoming more and more prevalent. And in fact, when we're thinking about care and what systems do, we're seeing that health systems tend to put people into situations that weren't common 20 years ago. So now when someone's in the hospital and gets discharged, they're a lot sicker when they go home. They have a lot more need. And the family caregiver is the person who picks that up. And so this is an area that I think all of us need to be focusing on very differently. We recently did a study, actually a review of the last 30 years of the research that's been done on multicultural caregiving. And the vast majority of caregiving research, I don't need to tell you, has been done in whites. And the understanding of what's going on in other communities is really much more limited. And particularly when you think about the many different groupings within larger groupings. So Asian Americans include over 20 different countries of origin. The Hispanic population includes numbers of different countries of origin. Each of these families have different beliefs, values, trajectories, and expectations about providing care. And our health systems really aren't geared towards understanding this very well. And as I think about what's going on in the school here and in the center, I think this is an area that you can really help in understanding the community and the particular needs and partnering much more robustly with different communities who have important things to say about what the caregiving experience is. So as I think about healthy systems for caregivers, I think we've got to start to think much more about families and communities, that we've got to look at the networks within which older adults are embedded. And if someone comes into the hospital, imagine who else is going to be there for them and who are those people who are going to help and take over in the next steps. We need to have better linkages for caregivers with formal systems. Think about the heterogeneity of our groups, the people who are here, people who are seeking care. And then with caregiving, which often takes many years, oftentimes people are engaged it's an average of over 5 years actually, there's a different set of skills that are needed with different conditions and even over time with one condition. And you can't get it all at one time. I remember when I first started working with older adults and someone would get a diagnosis of dementia, so many people would read the 36-Hour Day, which is a very popular book. And it talked about caregiving, and it enumerated every possible thing that could ever happen to a person with dementia. And it was one of the most depressing, difficult books, because you read it and you think, oh my gosh, is this going to happen to me tomorrow? Well, first of all, not everything's going to happen to the person who's afflicted. And secondly, it happens over a period of a number of years. And so working with caregivers, and for those of us who are the health professionals, we've got to think about what do they need now? And as caregivers, being clear about what would help you the most now. How can we partner to get what's needed at the right time? Because it can be very overwhelming. And then looking at the social context in our neighborhoods, what can we do within our neighborhoods to strengthen those connections and identify the assets that are available, looking at it from a long perspective. So as I conclude, I've raised a number of different issues that relate to systems of care, the healthcare system itself, what technology is doing, and some scary things and some promising things in that area, and then also family care. And at the core of all of this is really about creating a future where we have professionals who are well prepared to care for older adults, nurses, physicians, social workers, psychologists, therapists, but also in our communities, increasing our capacity to understand and deal with issues of aging in our families, because we're all going to be dealing with it in one way or the other. And so we really need to think about approaches that incorporate the expertise we need in geriatrics and a culture of health, a culture of owning this problem and owning the opportunity together to be able to create the best type of care, best types of services and supports for older adults and their families. So I'll close now, and I would love to hear from you, your reactions. What does this mean for you in this community? Any comments or questions that you might have for me? There's microphones available for the bold. There's a person in the second row here who's got his hand up. Thank you very much.
Hello. I was wondering what efforts are being made to help protect older people from overexposure to pharmaceuticals.
Oh boy, is that a great question. You've raised polypharmacy is one of the biggest problems and actually the leading cause of adverse events for older adults. I think that one of the most important things that we can do to deal with that is having a really strong geriatric team who's helping to evaluate what people are on. And I know that's something that's going to be launched here with you already have the geriatric pharmacology consults available at the center and with the new consultation service. But a review of what meds somebody's on and whether they're still indicated. What tends to happen is more and more gets added over time, and we don't always look at the interactions. And the average person with a number of chronic diseases usually has even more specialists, and they're prescribing different things and not necessarily looking at it holistically. So the core of solving that problem is bringing it back to a single person who looks at the entire profile and looks at what's really needed. Sometimes meds get started for a certain problem that goes away, but the med doesn't go away. So sometimes it's simply cleaning up that sort of thing. But then also there's progression of, the pharmaceutical industry is progressing with new drugs that may be more effective, so getting out the ones that are not effective and replacing them or getting rid of them entirely. And then doing it based on evidence. So I think it's a really important question, and it's something that certainly resides within primary care and geriatric consultation, I think, to really bring that home. Yeah. Other comments or questions? Back row.
Hi, thanks for coming. My question is about the elders that I see in practice that come to the hospital for something relatively simple and they get worse. They have dementia and it's triggered far worse by being in the hospital, et cetera. Have you seen any effective interventions that can help keep elders out of the hospital or keep them from getting worse once they're in? A lot of them linger waiting for placement and get worse.
Yeah, I hate to say it because I've sort of grown up in hospitals and love them, but I think avoid them at all costs, for one thing. It's about really doing whatever is possible to detect when if someone has a chronic condition, if there's a change in that condition, so you can avoid hospitalization. And that's about really understanding what to watch for and what to manage. But some of it's unavoidable. There's times when a person absolutely needs to go to get evaluated and to receive care. And then I think hospital systems can do a much better job, first of all, even understanding that they're dealing and caring for older adults, that a lot of environments in the hospital are not set up for people who have sensory impairment, even loss of hearing when you don't have your hearing aid with you, or I'm just absolutely immobilized if I don't have my glasses. I have very poor eyesight. And when you deprive someone of sensory stimuli that are appropriate. The distortions that happen are really problematic. There are a lot of programs out of the NICHE program. Have you heard of NICHE? Out of NYU, the nursing improvement, nurses improving care for hospice, started as hospitalized elderly, but now it's health system elderly. And there's a whole set of protocols around what geriatric nurses need to understand to provide good care, to detect delirium, to detect the issues, as well as lots of protocols and guidelines for how do you implement them in a system. So screening for falls, screening for polypharmacy, the kinds of things that get someone into trouble. Part of it is when someone gets to the hospital, very quickly figuring out what they're at risk for and mobilizing the right services so that it can get prevented up front or detect a problem early. Those are really crucial. And then in the post-discharge time, more and more the programs, I was talking with Dr. Phillips before about the transitional care programs of where you look and help someone navigate that transition from the hospital back to the home. Sometimes the reasons people come back is because they didn't get in to see their primary care provider and get their prescription adjusted, or they couldn't fill their prescription, and then they're back in trouble again. So strengthening those ties so that when someone leaves, they have what they need, the home's ready for them, they can be successful, and there's follow-up. So it's this fragmentation that's the problem as a systems level, but in addition to that, there's geriatric knowledge that's special, expert knowledge around what do older adults particularly need and how do you prevent those issues. And with the NICHE program, over 600 hospitals and many nursing homes in the country are members, and you join as a hospital. And then it provides training for the nurses to actually become certified as geriatric resource nurses. And then you also get all the protocols and the systems type tools that help with that. I don't work for them, it's not a commercial, but I found them to be incredibly useful and helpful. Yeah.
What would you offer as guidelines for converting from a family practice physician to one specializing in geriatric medicine?
I'm sorry, I don't quite understand the question.
I have a family practice doctor. I've always used that as my gatekeeper.
Yeah.
At what point, or what symptoms, or what goals, or something that I do to go to a specialist in geriatric medicine?
What a great question. So I think that it's about complexity of what's going on for you. I'd say if you have more than a couple of chronic conditions that you're taking, more than quite a few medications, and if you're starting to have any problems with function that are concerning to you, so concerning about your future with your physical abilities, with your cognitive abilities, that's a good time to get sort of a check by a geriatrician. You may not change your care completely, but a geriatrician could give you some guidelines about what to watch for, what to think about, what's on the horizon, what's potentially on the horizon. They don't have a crystal ball, but they can tell you what to be concerned about. And then, I would assess to see with your family practice physician, how prepared are they for caring for older adults? I'd ask, how many people in your practice are over 65? And what's your background in that? Many family practice physicians age with their patients, so they become experienced as they go along. They retire and you go through them, and if you're a healthy person, you've retired several of them by the time. But I think it's good to get that consultation and find out where you stand. And certainly if you have complexity, it's a very good time to get that type of it. It's very difficult in many communities to find geriatric expertise. So you're very lucky here in Reno to have that. There's a question in the second row here. Oh, let's go to the back too. We haven't gone to the dark part of not that you're on the dark side, but, and then we'll come to you in the front.
My question is, what about somebody being discharged? Do you have any data that supports patient income versus patient education and the ability to perform ADLs?
Clarify you're talking about correlations between function and
income
and education
and function.
I haven't run that particular correlation myself, and I'm not not, I'm imagining that, but I think that what we do know is people who have less education over their lifetime and less money are less healthy. So it's not so much about them themselves and their capability and their potential, but it's about what's there in the context to support their health and the resources to support their function. So, for example, my dad last year fell and fractured his pelvis. We had the ability, with knowledge, with education, with money, to be able to, modify his home, get some help in there for the time that he needed it. Another person who doesn't have the education and quite frankly, the power of influence in the health system, which education brings, and doesn't have the money, may not be able to set up a home to receive a person as easily with a complicated health problem. So there's a very tight connection between our social determinants and our risks for health disparities, for sure. And so in caring for older adults, part of what we need to be asking as nurses, as physicians, as members of the care team is, so what is this person, not just as what's on their list of diagnoses and their meds, but who's there to care for them? What are the resources? What does their home look like? Many people get discharged under the bridge, not to the home. So what about people who are homeless or don't have those supports? Well, I think we need to really focus on that as we're planning for older adults, because the context is vital. Something as simple as nutrition. Does someone have the ability to have access to prepare a meal? That's something that can be a huge determinant if someone ends up having problems later. Did I answer your question?
Yeah.
Thank you.
I guess I was just looking for if there's any data that says that a person who goes home with a lower income has a lower success or a readmission.
There's a huge set of data around unequal, with the health disparities, and the IOM report called Unequal Treatment outlines a lot of those issues along the lines of economics, racial and ethnic differences, and also education. And you can see that there are, and within all populations, those social determinants tend to play out. Yeah. There was a question up here, and then we'll go back to the dark side again.
Hi, I'm a retired elementary music teacher. This is my 6th year of retirement, which I'm loving. So I am not part of the healthcare system, but at my age, I've been starting to experience familial hospice care from family members who have deteriorated recently. My mother is 94 and a half, and she lives in independent living, but my sister and I are finding more and more necessity to have her watched. She has dementia. But I have a former high school classmate who was the main caregiver for her dad and her mom. Her dad passed away last November. Her mom passed away a couple months ago. And and my brother also had a sister-in-law who was feeling, and all three of these have passed away. And both my brother's wife and my classmate had the pulse, had everything in writing about the living will and trust. However, once these three individuals were admitted to the hospital, the family members were not allowed to bring them home for hospice care. And I was never aware of this myself, and perhaps you're not either, but apparently it depends on the hospital, the doctors, whether or not they allow that person to go home. So again, I don't know if you had...
Was it because of access to the hospice benefit, or was
I'm
the
not really sure the
preference?
details, but I'm just wondering, is this kind of a problem that we don't even know about? And as you say, you don't want to go to the hospital unless you actually have to, but
Yeah.
this makes me think, I don't want to go to the hospital at all.
Yeah, yeah.
So perhaps you could address that a little bit?
The PULST is one thing, which is it's a physician's order for life-sustaining treatment, which is a very important document that says, don't do certain things to me if I get into a situation where I'm in a life-threatening situation. So it deals with the moment of death, really. What it doesn't deal with, which you're talking about, is how do you have a good death and how do you have the right care as you go along. And that is a very tough thing to navigate, because most people don't want to think about it until they're really close to it. And in fact, we should be thinking about it, and our advanced planning for it should come much earlier in life. And we spend way more time planning our estates than we do planning our life for the last 10 years. And so the suggestions I would have is there are services. Hospice is available in homes. It's available in settings like skilled nursing. It's available, palliative care is available in hospitals. But part of it is being ready and communicating with your team way in advance that that's what you want. So having the conversations with your primary care providers, if you get to the hospital, start the conversations about if something happens, what you would like. And as a family member, starting those conversations and having them. It's really crucial to do that. And, times when we get together, like Thanksgiving with a family, it's a really good time to actually have some touch base on what are you thinking, what do you want? Because it's hard to make those decisions in the last minute. And it's often too late then, because then, it's late at night and you're getting told something that's not going to be consistent with your wishes. So I don't know if that would have helped in your particular circumstance, but I know that having those communications and documenting them and having everyone on board increases your likelihood of getting the right services when you need it. Was there something in the back? Somebody had their hand up, I thought. Yes.
Hi. I'd like to talk about more of the economics, the cost of pharmaceuticals. We've had some cases caring for an elderly parent where the cost of a pharmaceutical suddenly jumped. The physician did not know that. We only found out when we went back to the pharmacist to renew the prescription, and it put the elderly person in the position of deciding to eat or take their medication. Is there some way that can better coordinate an understanding of the cost of a medication so that the patient gets the medications that they need but don't have to make decisions on can they afford it, what do they have to sacrifice if they need that medication?
Boy, I wish I had an answer to that conundrum, because what you're describing is not just the cost at the beginning when you get a prescription, but it actually changing as time's going on. I think the one way to deal with it is to be monitoring that price as you're going, so you don't get bad surprises. But that's tough. When you renew a prescription, you could always ask at that time what the bill will be. So that's and that gives you immediate answer, so that if it's higher, you can look at something around that. The other thing is a lot of pharmaceutical companies, they don't advertise it real well, but they have programs if you have high-cost medications that you can ask for relief, and they'll grant that, but you have to ask for that. And that would be a circumstance where I would encourage someone to do that, to say, I wasn't expecting this increase, and have a negotiation around that. But it's a really tough problem. More and more we're seeing with health systems that there's formularies, and they're actually controlling the costs more as part of the bundled payments around care. So I think there'll be a little bit less of that ability to just off on the side in a rogue way go increase drug prices. But we saw in the news recently some examples of that, which were quite shocking. Yeah. There's a comment over here? Question. How are we on time, Peters? This should be the last question? Okay.
I was curious, when you go into your first visit with a geriatric specialist, what load of paperwork would you tend to bring in with you? I mean, would you want to set up appointments with your other practitioners to just kind of gather your health history, or how would you go about that?
So what a great question. I would say that always be the owner of your health data, no matter what. Don't wait till you're going to see a geriatric person to do that. Just, as a routine, make sure you're collecting your own data. So part of what an AARP actually has on their website, a really nice document that you can download, that you can fill in the information that's your record. So it's important to know sort of what your conditions are, what the treatments that are in play are for those, what your medications are. But then it also asks you questions about sort of what your resources might be in terms of if you needed help with certain things. And so filling out something like that that's comprehensive and updating it is a really good idea. Keeping dates, logs of things that go on, changes in medications or new diagnoses. And if you don't have that now, it's a good time to get that data collected so that you have it. Relevant lab work. But really the key issues, I think, for most people to work off would be an accurate history of your conditions and the medications that you take. That's a good place to start. The other part is to identify if you have a durable power of attorney, who that person is, and identify that person. And it's really important. A lot of people do that, and they talk to their lawyer about it and make a DPOA, but they never tell the person. Or if they tell the person, they say, hey, you're my DPOA, but they don't say what you want. And it's really important to follow through on that. If you've got someone you've appointed or named, that you say to them, this is what I really want. I mean, my mom did that, and I said to her, so what do you want if you need me to make a decision for you? And she says, oh, you know me. I said, no, I really don't. Please tell me. And when she started to tell me, it was really different than I would have imagined. And I was surprised, because I thought I did know her. And I thought it was going to be just no surprise. But, it's really important to have those conversations. So that would be part of what I'd have in the record as well.
Thank you.
All right. Any final comments or questions, suggestions, ideas? Yes, Miriam's in the dark side there.
Well, you know that one of my near and dear to my heart is the whole issue of family caregiving. And to me, one of the concerns is that the need keeps getting greater, the demand keeps getting greater, and I don't see that the support is really coming through. What are your thoughts on ways to actually address this in a way that people can stay in that role without losing their own health or their own economic stability?
Well, I think as long as we think about it as a one-on-one problem, it's not going to ever be enough. But if we start to think about it at more of a community level, a neighborhood level, there's more hope. I was last year in Seattle at an elder-friendly conference, and I was really impressed that what they'd done from the Agency on Aging there is go out into every neighborhood and ask them to organize an assessment of older adults in their neighborhood and who's there and what's going on. So on a block, you could figure out who's there, what are the situations. And I thought about this on my block. I would be happy to walk 2 doors down and take someone's trash out at night so that their daughter doesn't have to come from 20 miles to do that. If I knew that, I would do that. And I think neighbors can help neighbors if you know that there's issues. Whether it's in the faith community or whether it's in whatever kind of grouping we can think about, I think we've got to be more creative in figuring out how we cross-cover for each other, because people need lots of different things. One person doesn't have to do it all. And a lot of it can be kin, not family, and kith. So we need to find those webs of connection and really look at our communities differently. When I was in Hong Kong, I was amazed to see that the playgrounds had been converted, some of them from being kids' playgrounds to being places where people were doing Tai Chi, and they had bars so people could grab and do exercises, and full of older adults who were out there together as a community. And those connections and finding ways for them to gather in a community, in a public place, that creates ties. Because it's not all about young, healthy people caring for old people. Many older adults can care for each other. You got brains and brawn, and you can be 90 with brains and brawn, and the two of you together can do a whole lot. So, how do you pull together different resources people have and not look at it as a black and white situation? I think that's really important. Because if we think of it as a scarcity issue, it is. But we've got to look at how to build capacity and strength. Well, I've enjoyed being with all of you so very much, and thank you for having me. I wish you all the best. Thank you.
Thank you so very much.
Pleasure.
Thank you very much. Of aging in our society and those systems. And when you look around the room here tonight at this event, we have people from every corner of that system. And the question we have to ask ourselves is, how do we come together in collaboration to bridge those gaps and create an integrated system that's really going to help to benefit quality of life at the individual level and the community level and the organizational level and the societal level. And that fragmentation really exists all over. Someone asked a question about the medications and the challenges of medications and medication therapy management. We do offer that service through the Sanford Center, and we recently had a client that came in who was on 42 different prescription medications prescribed by 7 different providers. And so for that individual, their providers were not talking to each other. And it takes that individual to look at that information and sift through it and understand how to align it with optimal outcomes. And I think that this presentation tonight hit on all of the issues that are relevant for those systems. When you think about what's happening in healthcare, and the challenges that exist in the lack of communication across disciplines, the lack of communication across settings. When you think about the technologies and the opportunities that emerging technologies are going to provide if we can manage them in an ethical manner. And then I was so pleased, Dean Young, that you spoke about families and the role of families in community, the role of communities in supporting families and supporting elders, and thinking about how all of these different dimensions connect. Because ultimately, by bringing all of you together, by bringing all of those pieces together, that's how we're going to enhance the quality of life for elders throughout the state of Nevada. And I'm just thrilled with this presentation tonight and feel that you were able to join us. Thank you very much.